Are you tired of sifting through endless health advice that promises quick fixes but delivers nothing but frustration? Welcome to the Anti-Macro Podcast, the go-to place for scientifically backed yet digestible health and fitness wisdom without the fads or gimmicks. Whether you're looking to ditch chronic dieting, optimize your hormone and gut health, or simply find balance in your wellness journey, you're in the right place. I'm Coach Diana Lee, your no-nonsense guide to transforming your health and mindset for the better. Each episode, I'll dive into topics ranging from nutrition basics to debunking common myths to cutting-edge functional health insights, sometimes featuring guest experts in the space. Get ready to learn, grow, and take actionable steps toward a healthier and happier you. So grab your favorite beverage, kick back, and let's dive in. Thank you so much for joining me, Barry, here today. I always love to start things off by inviting you to tell my audience a little bit more about yourself, and I would love for you to tell them a little bit about how you became an expert in all things sleep and how sleep impacts health.
Well, thank you very much for having me on the program, and I would tell you that I do love sleep, and that's got a lot to do with probably how I ended up in the field of sleep medicine. But actually, divine providence put me into the field because I'm an internist, not a psychiatrist, and yet since 1988, which is a long time ago, I have been working almost exclusively with individuals that have mental health problems and sleep problems. So because of that, we've pioneered many things about that comorbidity, people with insomnia, people with depression, anxiety, PTSD. And along the way, I had the great training with Dr. Christian Guilleminault, who passed in 2019, but at that time, and maybe even to this day, was the greatest sleep researcher. And he published, I think close to 1,000 papers. He was the one who investigated how there are so many things regarding sleep in women are very much overlooked. In fact, before the program, I just went back to one of the old papers from 1995, talking about how difficult it is to diagnose a woman with sleep disordered breathing. And that you won't believe this. He says in the paper, don't make the mistake that just because you put somebody in a sleep lab and the test came back with these low numbers, so, that must be nothing. He said, no, that may not be true. And so I learned about that phenomena. It's called upper airway resistance. And when I learned about it, I was stunned that over the course of my career in the 90s and especially in the 2000s, we kept seeing all of these individuals with sleep breathing disorders. Like most PTSD patients, according to our research, most PTSD patients who say, I can't sleep, or I take a pill for sleep, or I'm not satisfied with my sleep, 90% of those people have a sleep breathing disorder. So that's really mind-boggling because all these people are told that their sleep problems are mental. So we're going to send you to a psychiatrist or a psychotherapist. Now, this same pathway then opened up this door into perimenopause and menopause, where sleep problems are so common. In fact, in my training in the 1980s and 90s, we were told, well, you'll never see a woman at the sleep center until they're around 40 or 50. Well, why is that? Oh, well, because they're past menopause, and that's when they get sleep apnea. I say, so I won't see anybody before? They said, well, it turned out to be mostly true, but also they don't get referred. The doctors that are seeing them don't know anything about what we're going to talk about today. And the doctors say to them, well, this person probably needs a sleeping pill. So if they don't want to get it from me, I'll send them to a psychiatrist. That pattern is rife throughout the medical fields, the psychological and mental health fields. And as a result, we have a lot of people, millions of people, who are either undertreated, poorly treated, mistreated, because the concept of how sleep actually works isn't understood by most of these individual healthcare professionals. And so they just go about a very incomplete pathway to say, well, try some sleep hygiene, try some pills, try some yoga. And it's very sad and frustrating, and sometimes it makes me very angry. And when I am talking to the patients who are now my clients, because I don't have a practice anymore that way, I do coaching, I'm hearing the same stories. And I'm having to experience and share with them their frustrations and anger in dealing with healthcare providers that just give such short shrift to sleep.
Yeah, I see that a lot as well in my coaching is that it's very overlooked and it's not talked about enough for sure. And it's not taken seriously enough.
Right,
Let's back up a little bit and give a little bit more of a high level overview. Why is sleep so important, especially in connection to our health?
right. So to capture people's attention, all we have to say is something like this. Either don't sleep or don't sleep well, and the result is brain damage. That's simple. So what we learn is there's always, of course, people who say they don't sleep enough. That could be a societal thing, a cultural thing. Maybe they choose that. And then there's some people who have really bad insomnia and they don't sleep enough. But that's still actually on the surface of the way we see something as opposed to what's actually deep underneath, which is what we call a sleep quality issue. That sleep quality issue is the big driver of virtually all sleep problems. And let me say it again. If you don't get the right sleep quality, you are actually damaging your brain. And so when somebody comes along when you're in your 40s and 50s and you can't remember names and you think like, gee, my memory really seems, and they say to you, well, you're getting old, or you're getting menopausal, or you have depression. It goes on and on and on. But actually, the number one thing that's probably going on, something is happening in your sleep. And now let me just add one more thing. This research is something sleep doctors knew about for decades. Because we met people face to face telling us, this is the way I feel, this is the way I think, this is the way I remember. And then we treat their sleep problems and they go, wow, how did you do that? Are you guys magicians? I said, no, we're not magicians. We just understand what sleep is and we can help you get sleep better. But 10 years ago, what we knew to be true was documented by researchers in Rochester, New York, and in the Netherlands collaborating. I think it's a Dr. Nedergaard who discovered the glymphatic system. And the glymphatic system is the lymph system inside your brain that cleans out the toxic waste. And you'll never guess when the glymphatic system is most operational. Sleep. And you'll never guess when the glymphatic system works at its highest level of effectiveness and efficiency. Deep sleep. Therefore, if you don't get sleep, you don't get deep sleep, all that toxic waste is building up in your brain, causing brain damage, memory problems, attention problems, concentration problems, daytime fatigue, and downstream, years later, they're fairly well convinced this is one of the major pathways that leads to dementia.
And that's powerful because if we're looking at our long term health and longevity, we can essentially start now by honing in on our sleep to protect our brain health, which, I think that's really important to point out. There's so many reasons sleep is important, but our brain health should be a primary motivator. Now, when we're looking at right, there's so many reasons, but when we're looking at, deep sleep, REM sleep, uh, light wave sleep, all of these different phases of our sleep, and then our sleep quality, how exactly can a person evaluate whether or not they're actually getting the sleep quality that they need?
That is a fundamental question. It's a great question because so many people are either in denial about even considering the question, or what happens in probably the majority is what's called the normalization of your sleep quality. So I'll give you one of the most obvious classic examples. A person tells you their sleep quality is great. You go, okay, really? Tell me a little bit more. How do you feel when you wake up? And they go, I don't know, after my first, 1 or 2 cups of coffee, I feel pretty good. I say, okay, that's really interesting. Like, did you hear what you just said? You said you had to have coffee, caffeine, to actually say then, well, I feel pretty good. Well, what happened before the coffee? What was going on from the time you woke up in bed to the time you drank the coffee? For some people, that's 15 minutes. For some people, that's a whole hour. Whatever the time frame is, what I want to say is, here's what normal sleep is, whether you believe it or not. You wake up from bed, you jump in the shower, you usually would start singing something like, "Oh, what a beautiful morning." And you'd have all these creative thoughts. You get out of the shower, you get started in your day, and you know what? You wouldn't drink coffee. So how could you possibly do that without the caffeine? The answer is sleep is so powerful that when a person sleeps well, they're going to have great energy the next day. And yes, there are some people who take a little bit longer to wake up in the morning. That is true. It's called sleep inertia. But most of those individuals who know about that and can get through it often don't use caffeine. Some do, but some don't. And when they get through it, it's like, okay, well, why are these people using caffeine? Normal sleepers actually think it's weird to talk to people who use caffeine. By the way, I'm not a anti-caffeine. Caffeine is one of the greatest drugs in the world. It's saved more people. It's probably the most effective and widely used treatment for mild depression. So it's a great drug. But what I'm getting at is it masks this concept of sleep quality that you're talking about. So that's number one. So the big issue really is, because there's plenty of people that don't drink coffee, is how do you feel when you get up in the morning? You're supposed to feel great. If you don't feel great when you wake up in the morning, do you at least feel great within 15, 30, or 60 minutes? If you don't, that is called unrefreshing sleep. That's the exact same thing as there's something wrong with the quality of your sleep. But people, as I said earlier, normalize that. Because if you think about it, if you're a mature adult, reasonably mature, you're going to say, well, everybody ridicules sleep, and sleep is for sissies, and I can't waste time sleeping, so I'm just going to go and get my work done. And the younger you are, you can do that. You can push through. A lot of people can do that. The older you get, it becomes more difficult, and then caffeine comes into play. But the person could step back and say, well, gee, that's interesting. Why am I pushing so hard? Like, why don't I have this, like Joe over there and Sally, they've got all this energy. Like, where did it come from? And they don't even drink caffeine. They're probably normal sleepers, unless they're on some new stimulant drug that just came out from the pharmaceutical company. So I can tell you things that will make your head explode in terms of actually trying to pinpoint this, in the individual. Most people won't believe this, that trips to the bathroom at night are abnormal. And most people think that's crazy. Urologists say, well, 1 to 2 times a night's okay, and obstetricians and gynecologists say 1 to 2. Primary care might say 1 time per night. They all think that's normal. And I'm here to say that it's probably not normal. There's probably a very good physiological explanation for why people wake up at night to use the bathroom. It is, by the way, in my book, Life-Saving Sleep, but it's also on my website, barrykrakowmd.com, a free 5-minute video called Nocturia. And it actually explains that there's things that can go on in your sleep that make your kidneys work overtime. Bad sleep, kidneys work overtime. The next thing you know, you wake up at night to urinate. And so you fix that sleep problem, whatever it turns out to be, and you discover you don't wake up at night to urinate. Well, can you imagine how many people listening to this who actually are hearing this idea going, gee, I know somebody who has that problem, or they themselves may have the problem, because they've been told by virtually every healthcare provider it's normal to wake up and use the bathroom. And I'm here to say it's not normal. I'm convinced, because of the pathophysiology that's been described in great detail over 30 years ago, that you actually have an explanation and you can treat it, and you can no longer get up at night to pee. It's pretty amazing.
Yeah, and you bring up a great point, and that is we normalize dysfunction in a lot of ways. So you mentioned, how we reach for caffeine, and I think caffeine culture, coffee culture perpetuates this a lot, right? The idea that, oh, you can't talk to me until I've had my first cup of coffee or something like that, and we laugh it off.
Right.
Normalizing things like getting up to use the bathroom in the middle of the night and saying this is normal because so many people are experiencing it,
Right.
but not clarifying that this actually isn't optimal. This isn't how things are supposed to be. And this should be a red flag that there is something bigger and deeper going on.
Absolutely. Absolutely. And people just continue to do that. And you'll have people who will hear what I just said and they will say, that's impossible. Why? Because they've heard so many doctors tell them it's normal to wake up and urinate. They will hear about so many people who say, I wake up at night to use the bathroom. And they go, well, that just must be true then. Why would this one doctor have some special knowledge that nobody else has? How come all the rest of the medical field doesn't have it? And that's that phenomena that goes along with how knowledge is disseminated or not disseminated into healthcare circles. Most sleep doctors know what I just said is true. And they know that there is an actual sleep explanation for trips to the bathroom, and that treatment will often lead to a reduction, in some cases an absolute cure, no more trips to the bathroom. So most sleep doctors know that. A fair number of cardiologists know it, because cardiologists are getting really involved in the field of sleep medicine. But those are the only two fields. So you could have somebody, I'll give you the classic example, somebody is seeing a psychotherapist for PTSD. They've got anxiety, depression, and PTSD. They're on multiple psychotropic medications. And they're saying, thanks for the therapy, and it's really helping, but by the way, can you help me with my insomnia? The therapist says, well, what do you mean? Well, I'm waking up at night to pee, and then I have trouble going back to sleep. And then they go, okay, well, how many times do you wake up at night to pee? I say, well, it could be once, it could be twice, sometimes it's 3 times. The therapist could say something like, well, why don't you talk to your primary care doctor about that then? But the primary care doctor then says, okay, well, that's normal. But my therapist told me to talk to you about it because maybe she was wondering if it wasn't normal. All of those people are in that paradigm, or set of circumstances, I should say. They probably have a sleep breathing disorder that's causing this problem with trips to the bathroom. And none of these people know it. So here's another example of knowledge that is not diffused into healthcare, into nutrition, into fitness. You have all kinds of people that are bodybuilders, people with strong interest in nutrition and fitness who are not sleeping well. And because they do all this activity, that's great, and they may hit the sack and pass out and think, okay, well, I did well, I got my 6, 7, 8 hours, but they really have to inspect it more closely and discover whether or not there's something else going on. And a lot of them think that, well, I'm too young to have this, I'm too young to have that. They'll find out sooner or later. It gets worse as you age, and especially in the perimenopausal and menopausal phases.
Yeah, and let's get into that a little bit more. So in your work with women, you've mentioned that a lot of sleep issues that are more specific to women are rarely discussed in mainstream scientific literature. Could you share a few sleep disorders or symptoms that are unique to women and often go undiagnosed?
Well, let's start with the one that's the most important, because we're talking about people dying, which is always catches people's attention. We have this problem, particularly in a state like Georgia, where I live, but many other states as well, where we have a cohort of black women that are overweight and have high blood pressure. Okay? Now, if you're a sleep doctor, you know that if you have obesity, you have a great chance of having sleep apnea. But if you have high blood pressure with that, that means you have an even greater chance of having sleep apnea. Why am I talking about this cohort? Because when they're pregnant, they get the condition called preeclampsia, which can lead to the death of the mother, the death of the child. And there's an epidemic of that that's been talked about for several years now, in large part having to do with obesity. But here's the thing. CPAP, a device that was invented in 1980 by an Australian researcher, Colin Sullivan, is the same man who showed in the 1990s or 2000s that if you took a pregnant woman in the hospital with preeclampsia and put a CPAP device on them to breathe and sleep with, they left the hospital completely free of a preeclampsia within 48 hours. He's published more papers on that, and guess who doesn't read these papers? Most obstetricians. So here's an example where there's a very serious condition called preeclampsia. It occurs in many women who are at risk, and it is absolutely linked in many cases to sleep apnea. And yet the doctors, only some, now know that in the third trimester, maybe they've got to put a woman on CPAP. Why? Because they're snoring more and maybe they're more tired. Maybe we should try CPAP. They may not even know they're preventing that individual from going into preeclampsia. So that's one. That's one of the most serious of all. The other one that's more common in a much larger cohort is in the perimenopausal stage. We know that something happens to the airway dilator muscles in a woman's throat. One theory had always been that changes in progesterone levels may have led to a weakening of the dilator muscles. But again, this great researcher, Dr. Guilleminault, published this data in the 1990s, and he talked about how perimenopausal women walk in the door saying either I've got insomnia or I just don't feel rested. Either group, get this, either group had sleep disordered breathing. But the group with the insomnia, it was much more difficult to diagnose it. Not to mention the fact that anybody who would look at the woman who said she had insomnia is going to go, well, I don't know what you're talking about. Go see a psychiatrist. Go see a therapist. You have insomnia. That's a mental condition. And Dr. Guilleminault had the courage to test these people. That's where we learned about this, and we continued in that vein from the 1990s all the way to the present, where we discovered the link between insomnia and sleep apnea is crucial in a vast majority of individuals. But that's a big one because perimenopausal women will go to their doctor saying, I've got these symptoms. And by the way, my sleep is disturbed. What can you do for me? Well, the answer is always going to be, oh, well, do some sleep hygiene and do some maybe hormone replacement therapy or take this sedative. I'll write you a prescription. Instead of saying, get a sleep study. Another component of that is another disorder called restless legs and leg movement, which again, by the way, may be common, according to some sleep physicians, in people that are heavily into training, particularly into running. Nobody actually knows that for certain. There is no great research. It's just a speculation. But leg movements also can fragment your sleep so that you end up feeling unrested the next day. Those are probably two of the biggest physiological problems. And then the psychological is largely the mental side of insomnia, which there is, circadian rhythm issues. People talk about hormone issues having something to do with sleep. I don't feel the research on that is conclusive, especially when I consider that there are people who have had sleep problems in perimenopause and menopause. They go on a PAP machine or they get medication for leg jerks and they go, well, I'm better. I'm better now. So wait, are you telling me that the CPAP and the medication changed their hormones? Or are you saying that it treated their sleep and that's why they're better?
And that's part of the problem too, is when we are going to maybe our primary care physician and we're expressing, I'm having issues with sleep. Oftentimes the level of care is not actually getting deep into what the root cause of the issue is. And I see a lot of, even some of my clients are on some heavy duty sleep medications.
Really?
And that's what they're given for their sleep disruptions or their sleep problems or their insomnia. But no one's really spoken to them about doing things like a sleep study or digging deeper into why they're having those terrible sleep issues in the first place.
Somebody might have had a sleep study and was told, well, that we couldn't find anything. My answer to that is go back and do 5 more sleep studies. I mean, it's hard to find actually the right data. The technology used for sleep studies is incredibly primitive. I mean, like within 10 or 20 years, they will be laughing at us for the way we were trying to understand sleep in the laboratory. For whatever reasons, though, sleep testing got linked to insurance coverage. And so insurance coverage has stymied the field of sleep medicine now for close to 30, maybe 40 years, demanding that you need to show certain criteria on this outdated technology to prove that somebody's got a sleep breathing disorder, and then we'll cover it. When really the technology should have been discarded a long time ago, and new technology should have come about. There's, like, when you think of all the wearables now, those things will actually eventually probably be better than what you can get in the sleep lab. I'm guessing that it'll be like that at some point, maybe in a decade. Why not? To be able to get all that data and say, oh, well, this is really what is going on with your sleep and your breathing and your leg movements, and we could do it all at your own home. We didn't even have to bring you into a laboratory. God willing, that's going to happen. I don't know how or when, but there's reason to think that will happen because the field of sleep medicine is very stuck on this idea, this model about, well, let's measure sleep in 30-second intervals. Why? Who came up with 30 seconds? That's ridiculous. Your sleep should be measured every second by what's happening with your brain waves, your breathing, your leg movements, and so on, your heart rate. So that more advanced technology is coming, and that will make a big difference. But right now, people would do well if they're on all these medications to ask these other questions. In my book, I go into great length about this concept of sleep quality. In fact, I have another book that I just released a couple months ago called Fast Asleep. And in that book, we go into more advanced ways to approach the sleep hygiene issue, as well as early treatments, if somebody who has a sleep breathing problem. But a person can begin to ask questions like, do you wake up with a dry mouth? Do you wake up with a headache? Do you notice changes in your memory, concentration, and attention? Do you have high blood pressure? Do you get more fatigued and drowsy in the afternoon? All of these things point to the possibility of a sleep quality problem. It's a really good thing to find somebody in your neighborhood, in your family, in your workforce, your social circle, who's a normal sleeper. Find that person, get them to tell you what normal sleep is for them, and go, wow, I don't have that. So you must be normal, and I guess there's something going on with my sleep. We actually, years ago, did that. We recruited some normal sleepers because we wanted to see what was going on with them. And they would tell us these stories just like I'm telling you. I said, well, what do you do at night? You go to sleep. And then what do you do? Well, I get up in the morning. Okay. And then what do you do? Well, I work all day. I get everything done. Okay. Do you drink caffeine? No. Do you take a nap? No. Does your energy flag? No. It's a really interesting clue. With somebody, based on normal hours now, if you are a sedentary person in the evening hours, like you're on the computer, you're watching movies, you're watching TV, and you've been working a regular 9 to 5, job or 9 to 5 cycle, whatever. If you're doing that in the sedentary hours, huge probability there's something wrong with your sleep. A normal sleeper in the evening hours has a hobby, is going out to the Parent-Teachers Association meetings, going out to a religious activity, is just going to the gym. They're doing stuff in the evening hours. It's like, well, I still have energy. Like, they might even be going for a very long walk. But they're like, why would I sit in front of a TV? What exactly am I doing when I do that? But you see, when you start to lose energy in the evening, Now you could argue, some people say, well, I want to wind down. Okay, I'll accept that. But some people don't need 2 to 3 hours of like screen time to wind down. It's also a possibility that you've got lower energy and you need that passive relationship that just helps you relax, but you don't want to get up and do something else. So it's a very, very big red flag, because a normal sleeper is the person who's an up and atom virtually all day long. I'm not saying they don't use the screen, but they use it in a very different way because they're not attracted to it.
Well, also how much of that, right, is the impact that the constant exposure to blue light has on our sleep. And it's this ugly cycle that people are getting stuck in because they view winding down as usually sitting in front of some kind of screen. I see it all the time. And then the screen hinders their sleep. Then they have no energy to do things in the evening. So they wind down in front of a screen and so on and so forth. It's like this recurring cycle. And it's sometimes, not sometimes, actually, all the time when I work with clients and they come in, I ask them, what is your wind down routine look like? And I usually advise them, let's start cutting out screens a bare minimum of 30 minutes, but ideally more than an hour before bed. Let's start replacing that with actual activities that help you wind down, things that are relaxing. You know, it could be going for a walk at night. It could be stretching. It could be reading a book. It could be something that's away from a screen. And all of a sudden they're like, I'm sleeping better. Yeah, well, those screens are impacting our quality.
Absolutely. It's a very important point. I will tell you, I'm a research skeptic of long standing because I've learned about so many things that come and go. I'm not a huge advocate of the theory, what you just said regarding the blue light, but absolutely everything else you said is what is making the difference. I don't know, I honestly don't know if their removal from the blue light is what's helping them. I'm not convinced it is. I'm convinced what you described about how they went into a different level of activity, a different type, because you're talking about something that in my books I've written about in several places, and that is, what is emotional processing in the final third or the final quarter of the day or evening and so forth. That emotional processing is a reflection on the satisfaction you got out of that day. And if you don't have satisfaction from that day and you don't do any emotional processing in the evening, then you have insomnia. So when you meet most insomniacs, they either have anger or frustration about something that's going on in their life. And unfortunately, because they don't know how to process it through some of the techniques you've just described perfectly, and some people, of course, need even more advanced techniques to get into those emotions that they're struggling with. But when they don't have that, they do end up with, sleep disorders. And so the evening ritual is very telling about what people do. Some of the people who are in front of the screen do just fine because they just finish off 2 or 3 hours of movies and then get into bed and go to sleep because they're low energy, and they could have gone to sleep earlier, even gotten more sleep, more bad sleep, as we call it, bad sleep quality, and they don't realize that. But for people who are fitness conscious, like you're describing, your regimen is outstanding, and the only addition to it is the one where we ask the question, what if the person does all the things you said, and then they go, but I got to take this pill to go to sleep? Well, that's an insomniac. They've now become hypnotic dependent, as we call it, and nearly all people who are hypnotic dependent have one of two problems, and usually both. One is they develop the pattern called losing sleep over losing sleep. And when that happened, their doctors said, okay, well, I'm going to give you a pill then because you're just getting too freaked out about this. And in a certain way, that was correct. Because if you start getting obsessed about your sleep and develop sleep anxiety, you can become suicidal. So, that's very important, that the person has to recognize that, and sometimes the pill can make a difference. But that's not the long-term solution. The long-term solution is stepping back and going, all right, what is the emotional issues that are actually keeping me up? And all I got to do is look back on my current day, maybe the day before, maybe the day ahead, and you'll find something. You'll always find something that's bugging you. And unfortunately, if you are an insomniac, you tend to have a higher IQ and you tend to be very intellectual. These are generalizations, but they're relatively true. And you tend to think that you can think your way out of all your problems. And that's not true. You can't. There's a certain amount of emotion that has to be involved with the thinking to actually process all of that. So those are all dealt with in my books. It's been an area I've been interested in for over 30 years.
That's interesting. And let's backtrack also to the sleep studies. So you had mentioned something much earlier in the podcast that it's actually harder for women to get diagnosed. I'm curious, is that because the equipment is not up to date, as you said, or are there other reasons for that?
Without having to insult and degrade what's going on in this process, let me make it very simple. The technology is there to be able to score breathing events or leg movements, but what's happened is the field of sleep medicine has gotten so confused and so stuck in a tunnel as to how it wants to look at things that it forgot everything that Dr. Guilleminault researched in the 1990s or chose to ignore it. And so let me give you the best example. We call this a closed airway. You know, my hands are together, there's no space. That would be an apnea. Well, if you give somebody a little bit of CPAP, your airway opens up a little bit. That's called a hypopnea. Those two breathing events, apneas and hypopneas, are what something like 70 to 90% of sleep doctors measure, usually measure accurately, but that's all they measure. But it turns out to go from hypopnea to normal, there's a space in between. I call it the third breathing event. Dr. Guilleminault called it upper airway resistance. In the sleep medicine world, they call it flow limitation. Another group calls it respiratory effort related arousal. You notice, like, that's 4 different names, which is ridiculous, that there's got to be different names for the same thing, and that reveals part of the confusion. But most doctors literally say to their patients, oh, that's nothing, just ignore that. Oh, you have mild sleep apnea, yeah, don't worry about it. So the women go in all the time to sleep centers and get this diagnosis called, well, it's kind of mild sleep apnea. I don't know if you want CPAP, you can try it, but I don't know if it'll help you because it's really hard to use CPAP, which is correct. It is very hard to use CPAP, which is why in 2005 we stopped prescribing CPAP. And we used a much better mechanism called bilevel, which is a very advanced form of CPAP. And that, of course, is described in great depth in my book and in my other books, because it turns out those devices are so much more comfortable. In fact, ResMed actually made one designed for, it's like a CPAP for her. Like the technology actually recognized that women may need a different kind of support system for the way they experience that pressurized air coming into their body. Bilevel is probably the best device out there, and there are variations on bilevel. But again, this is the same problem. Even if a woman goes into a center and gets diagnosed with one of these subtle breathing events, the doctors will again say, okay, but here's CPAP. You see, we consider that close to medical malpractice, because if you're a woman with one of these sleep breathing conditions, the chances are greater than 50% you also have anxiety and insomnia. Now, why is that? Well, because it's not normal to not breathe. So if you're not breathing well all night long, you should wake up and be anxious. You've been struggling with your breath all night long. So naturally you would have anxiety. And eventually that leads to insomnia. So you would think the doctors would say, look, you've got this really subtle breathing condition. You've told me you have anxiety. You've told me you have insomnia. Let's not even go with CPAP. Let's do something else. And then let's even see whether you're a good candidate. In fact, in my book, I've done a thing that over the last several years, what I call conservative entryways into sleep disorder breathing treatment. So for somebody who's listening right now, say if you thought you had this condition, buy some nasal strips, buy nasal sprays, evaluate your nasal breathing. Most people discover who have these sleep problems that there's something wrong with their nose. Congestion, runny nose, stuffy nose, whatever. That has to be treated. So why not treat that now? And most people who do, they say, you know what, I'm sleeping better. So that's a very simple physical step. After they've done that, then they're a very good candidate to try to go further with something like bilevel. Back in 2005 when we made this switch, we never prescribed CPAP. Never. We went to all the medical directors in our area, even the ones nationally like Medicare, Blue Cross. We said to them, here's what we found. People can't use CPAP. We want them on bilevel. Here's how we're going to do it. And they said, well, as long as you've got it in your medical notes as to what you did and why you're doing it and how they responded better with this other device, they said you're fine. No insurance company ever rejected any of our prescriptions. And when we tell this story to other sleep doctors, they go, that's insane. Like, how did that happen? You could never do that now. We can't even talk to the insurance companies. So that's how bad that's gotten. It's very, very distressing.
And it's frustrating too, because I know that so many people don't seek out help or support with their sleep because they're afraid that they're going to be prescribed a CPAP and they're nervous that it's going to be uncomfortable, as you mentioned, and to realize that there are more comfortable options out there that people could utilize that just simply have not become mainstream. It's very frustrating to think that people are being blocked from better sleep, better health quality,
Yep.
all because we haven't transitioned to something that is more comfortable but also available.
All the time. Now, the other good news, though, is that for those in your younger populations, which does include anybody all the way up to 50, let's say, as long as they have good dentition, some of them are candidates for what's called oral appliance therapy. It's a dental device that holds the jaw in a forward position. Now, unfortunately, if you have a history of temporomandibular joint, TMJ problems, you may not be able to use it. But many people who are health conscious don't have TMJ problems and do have sleep breathing problems, and they could learn to get one of these dental devices and use it at least for a while and see some noticeable benefit. When I was first diagnosed with sleep disordered breathing, my first treatment was in 1998, and it was a dental device, and it was a miraculous treatment. And it was a miraculous treatment for almost 4 years, and then it didn't work as well as I needed it to, so we went on and moved on to PAP therapy. At that time, I used CPAP and auto CPAP and got to learn all about it and why it's not that good, even though I could make it work for me. But it was nothing compared to bilevel, which I had switched to around 2002. And then from 2002 to 2005, we began working and trying to figure out, we'll do all of our patients or do more of our patients. Finally, by 2005, it was a slam dunk. We just said, no, everybody gets bilevel, as long as we can prove that they have failed CPAP, which is something very easy to do in a sleep lab. Because you can just show that somebody is not sleeping well. You got them on CPAP? Hey, why aren't they going into REM sleep? Well, because they're in CPAP. Switch them to bilevel. 60 seconds later, they go right into REM sleep. It was an amazing thing to see that.
And so if somebody's listening to this right now and they are maybe prescribed CPAP or they want to advocate for better care for themselves, can they talk to their doctor about bilevel? Can a person advocate for this kind of device to be used for their care, or what do you typically see?
This is a great question because this will not surprise you about the problem with the narrative. So, like, the quick answer to your question should have been, yes, of course. But it's not. Here's what the long answer is, unfortunately. Number one, if they read my book, Life Saving Sleep, or they did a coaching session with me, they would sit and talk to me and tell me how they may have already tried what you just said. And they're going, wait, like, how do you talk to these people? Like, They're closed off. They won't listen. And I actually give them a narrative. And I say to them, you have to walk them through it. And I'll give you the best example that I have in the book and elsewhere. I recently did a lengthy essay on Reddit. I think it's the CPAP Reddit, and it's called The Crisis of CPAP Failure. And here's the analogy. If you walked into a psychiatrist's office and you said, look, I tried the SSNIs, the tricyclics, and the doctor says, oh, well, no problem. We've got this more advanced new thing out, and I think it could be good for you. Let me contact your insurance, and we'll get you approved. Well, that's the same thing with CPAP. If CPAP is no good for somebody, the doctor is supposed to say, well, we can try something more advanced. I'm just going to have to get insurance approval, but you haven't done well with CPAP. You found it on your floor half the nights, and you didn't even know how it got there. So that story is very common. But so if you walk in and you tell the doctor that, they'll go, what are you talking about? Because they'll say, well, you were wearing the device for several hours a night. I say, I know I was wearing it, but I wasn't getting any benefit. And the doctors don't register. And the difference, it's called in sleep medicine, they have a word called compliance and adherence. Are you using it? Which is like so dumb, because I write, like, if you got in a car and drove around in circles for 6 straight hours, did you get anywhere? No, you just used your car. And that's what's going on with this CPAP stuff. So I say to them, you're talking about efficacy. Use that word. They'll think, okay, wait, this guy's using $10 words. Efficacy. What do you mean efficacy? I'm telling you, the CPAP doesn't make me feel better. I've heard that bi-level might work for me. Will you be willing to let me try it? I always encourage people to be very diplomatic. And when they are, some of them actually see the doctor going, oh, well, okay, I mean, I haven't really heard much about that, but if you want to try it, I don't mind. I'll write you that prescription. Other doctors will say, well, you're really stupid. That's ridiculous. They're all the same. Bi-level doesn't do anything better. Go see another doctor. I don't really want to see you again. That happens. That's how bad this particular crisis is in the field of sleep medicine.
And learning patient advocacy is so important. I do it a lot with my clients as well, and asking for lab tests and whatnot. And you have to be able to go in and speak to your doctor and be very specific about what you want and why, and be able to justify it, which, it's unfortunate that that level of burden is placed on the patient, because in a lot of cases, unless somebody is listening to this podcast, reading your book or whatnot, they may not know better. And then thus their own limitations are limiting their care.
Right. It's unfortunate, but it's actually an omen, because healthcare is going to change so radically that the role of doctors and healthcare professionals is going to continue to decline in certain areas, such that the responsibility is going to fall almost exclusively on the shoulders of the individual, which in some ways can be very good. Not so much for the concept of diagnosis, but for the fact that making us more health conscious, nutrition conscious, sleep conscious. They go, I can take care of myself. I can learn to be a healthier person. But when I've got a problem, I'm going to now be able to go to so many resources and to get so many clear-cut pieces of information that when I go to the doctor, who might be an AI robot by that time, they're going to go, I think this is what's going on, and I would like to discuss this with you, and I want to know about these different treatment options that I've read about. People are going to be so educated that doctors are going to have to respect that these individuals no longer having this gap of knowledge. Instead, it's going to be, no, we're having a really good discussion about the different treatment options, and I'm hoping you can give me your expert advice on how to go next. But here in sleep medicine, they don't have that. They walk in the door and they go CPAP or sleeping pills, or CPAP and sleeping pills. Those are the options.
And you've expressed a lot of your frustrations with the sleep industry, the medical industry. You just mentioned kind of like your view of how things could possibly go. Do you see any of these advancements more now so where, do you see things moving in the right direction, just maybe slowly?
No, there's always hope, because number one, in my coaching practice, I'm seeing more and more people come to me saying, I want to switch from CPAP. I want to go to bi-level, and I want to figure out how to make that narrative happen. But guess what many of them do? They just ignore their providers. They go out and they purchase their own devices. I don't know how they do that because it used to be you have to have a prescription. Then what they do is they take their bi-level device, and you know what? They go back to the doctor and they say, well, I've been on bi-level now for 6 months and I've been doing a lot better. Doctor goes, oh, okay. Can I still help you? Or it creates a very different dynamic. The bottom line is there's so many other pathways that are happening with the wearables, the way people are going to be able to, there's too many people out there with sleep disorders. The labs can never handle the load. Probably within 5 or 10 years at the most, people will literally just be able to do all their testing at home, get very, very thorough testing. They won't even have to go anywhere. I would like to see a big change, which would be that CPAP would no longer need a prescription. And I would bet that's probably going to happen because there's never really been a safety concern about CPAP except for the big scandal that occurred with Respironics where they put a foam material in it which was dangerous to health. And so that was a huge scandal, and that company actually went out of business because of it. But in terms of the use of a CPAP machine, it's extremely rare. You'd have to have a certain set of conditions that they'd have to list, like if you had a history of a pneumothorax in your lung in the past, or if you're known to have heart failure. They'd say, okay, well, you got to see a doctor for these reasons. But the average person would be able to just go to the drugstore and buy a PAP machine, hopefully a bi-level, not a CPAP, and get started and get using it. And then they'd go online and they'd find coaches. Not just me, I'm a sleep doctor type coach. There's all kinds of sleep technologists that are running their own coaching programs. That change is happening now. People are doing this all over the world. I'm talking to people all over the world. I'm talking to sleep coaches all over the world. This is happening. It's small, but it's absolutely growing because people just are fed up with the sleep industry, and they know that the sleep doctors are not trying to make that advance. Maybe they will. Maybe the sleep doctors will. But in the meantime, a very large segment of people, especially younger individuals with sleep apnea, they're working with sleep techs, sleep doctors outside the mainstream, sleep doctors like myself, sleep coaches like myself, and they're making tremendous progress, and they're then telling other people, well, here's what I did, and it worked for me.
Yeah, and that makes sense. It's usually very consumer driven. We've seen that in the health and wellness space as a whole, that a lot of, coaches, even just like myself, we have been given a space in the market mainly because of the lack of care
Right.
that's been given
Right.
in healthcare.
That's great.
So it's interesting to see how that might grow.
Yeah, it promotes the individual responsibility that, if you think about it, should always have been there, but probably because of certain forces that came into play in the 1940s when the first health insurance programs came into being, and forever after, there was sort of this industry that got built up between the doctors, the pharmaceutical companies, the disease management specialists, whoever that happened to be, public health, and it all got to be like, oh, well, the doctor knows everything, so just rely on the doctor, and you don't have to know anything. But really, that always would have been a mistake. Long time ago, people always had something to say about their health. Now we're going to be reaching this new pinnacle, and the pendulum is swinging way into the direction of it's my responsibility, take care of my health, know what I can know, research what I don't know, and then seek help for, more professional assistance. But that's going to be happening. It's already happening big time. AI is only going to expand that. And we have the potential to become a much healthier physically society. We have a long ways to go in other areas, but physically we may make some really big improvements.
It will absolutely be interesting to see, especially with the growth of AI. We've seen it infiltrate so many different areas. We know people are utilizing it to navigate their own healthcare. And I can only imagine that people are absolutely using AI to navigate their sleep care as well.
I'm sure it's going to start if it hasn't.
This has been wonderful and so many really good, fascinating aspects that, I've learned from you. I really, really appreciated this. I would love for you to take the time to drop anything as far as where can people connect with you, continue learning from you? You've mentioned your book, so go ahead and drop those again here.
Sure.
But any other resources that you have that people can learn from?
Sure thing. Sure thing. So my website, barrykrakowmd.com, has many free videos on it that one describes about nasal breathing, a very important area of sleep. Another one talks about the trips to the bathroom problem. I also sell books and videos online as well. But on that website is where I have my link for my sleep coaching services, which are usually 1 hour or 90-minute appointments. I am considering and contemplating starting a podcast that will be about sleep and cover a lot of the material in my books. I also have a free Substack newsletter, fastasleep.substack.com. And as I mentioned, my two most recent books, Life-Saving Sleep and Fast Asleep, are both out and available wherever books are sold.
Awesome. Yeah, that is so helpful. And thank you so much again for coming on the show.
Thank you very much for having me. Sleep well.
Thanks for tuning in to another episode of the Anti-Macro Podcast. I hope you found today's insights valuable and actionable for your own wellness journey. Remember, true transformation comes from consistent, intentional steps forward. If you enjoyed today's episode and want to stay updated on all things health and fitness, be sure to hit that subscribe button so you never miss a new episode. I release fresh content bi-weekly every Wednesday to keep you inspired and informed. And hey, if you loved what you heard, I'd be thrilled if you could take a moment to share this podcast with a friend or family member who might benefit from it. By sharing it with others, you're helping them on their wellness journey too. Keep striving for progress, not perfection, and I'll catch you next time.